afternoon, everyone. I'm Michael Healy. I'm staff attorney with the New Mexico Legislative Counsel Service. I'm also NCSL Health Committee staff co-chair. And on behalf of the National Conference of State Legislatures, I'd like to welcome all of you to today's webinar, To Expand or Not to Expand, that is the Medicaid question. Today's webinar will discuss possible costs and cost savings associated with the expansion, as well as discuss issues for legislatures to consider as they make decisions about the future of their Medicaid programs. We're very fortunate to have two experts joining us today on today's webinar. Elizabeth Luukkonen, a Senior Research Fellow at the State Health Access Data Assistance Center, and Carolyn Ingram, Senior Vice President at the Center for Healthcare Strategies. She's also our homegirl in New Mexico and our very capable former Medicaid director. Elizabeth and Carolyn will introduce us to tools for moving forward in determining the costs or savings associated with expanding Medicaid. However, it's important to note that any algorithm or decision aid tool is only as reliable as the information available. Are the numbers accurate? Have the feds made all the necessary information available to states? Do the identified costs and possible cost savings represent what is really happening in the states? Each state will have to determine what tool or model best reflects their reality. We do know that all states are waiting for guidance on how DSH payments, or disproportionate share hospital payments, will be distributed to states and how states can transition to MAGI. In New Mexico, Medicaid expansion is an enormous topic. As of August, roughly 522,000, or over a quarter of our population of just over 2 million, was enrolled in Medicaid. As of 2014, it's projected that anywhere from 102,000 to 126,000 are expected to be added to those rolls if Medicaid is expanded to include childless adults as provided under the Affordable Care Act. And that would total 30 to 31% of our population, according to our University of New Mexico Bureau of Business and Economic Research. Right now, our executive, our Human Services Department that administers our Medicaid program, has applied for an 1115 waiver to drastically change the way our Medicaid program operates based on 4 principles. And one is a comprehensive service delivery system, a much more greatly integrated system of care. They want to emphasize personal responsibility, have some payment reform measures, and simplify administration. Right now there are 7 MCOs in our Medicaid program. They want to whittle down that number depending on the types of RFPs they get, responses they get. Using our Human Services Department May 2012 cost estimates, our Legislative Finance Committee did analysis that showed revenues would outweigh expenditures for new Medicaid enrollees in the first 6 years as the FMAP was phased down from 100% down to 93%. And then when the program is fully implemented in fiscal year 2020, the state is expected to incur additional costs and when the match is down to 90%. And the total savings to the state in the Legislative Finance Committee scenario is $443.6 million. And the Bureau of Business and Economic Research has recently reported new estimates that show a net gain to the state in terms of increased revenues and other economic growth in terms of $523 million. New Mexico has a very large Native American population. About 10% of our overall state population is Native American. About 4% of the state's population are Native Americans enrolled in Medicaid, or 40% of that population enrolled in Medicaid. With the Indian Health Service very chronically underfunded at about 50%, it's estimated, the IHA system very much hopes to benefit through a Medicaid expansion. As a low disproportionate share hospital state, our hospitals are very nervous anyway about the DSH payments reducing, and we have a lot of very widely dispersed rural hospitals serving low populations, so there's a lot of concern there. Our governor is considering whether to expand Medicaid to 138% of the poverty level to adults regardless of dependent or disability status, as the Affordable Care Act provides. I staff the Legislative Health and Human Services Committee, and that committee recently endorsed legislation for introduction in next month's 2013 regular session. And that would require our Human Services Department to expand Medicaid to adults below 130% of poverty regardless of dependent or disability status. We'll see whether the governor vetoes that bill or signs it, or if she has decided in the meantime to expand it anyway. She may be waiting for the fiscal cliff or sequestration to develop further. Secretary Sebelius' letter and frequently asked questions memorandum of December 10th offered some important insight into the likely content of coming regulations out of HHS. Namely, New Mexico doesn't have the option, as some people here have discussed, of expanded only to include those with incomes under, say, 100% of poverty or some level less than the Affordable Care Act number of 138% with the MAGI disregard. New Mexico has also been covering childless non-disabled adults with incomes up to 200% of poverty, and that's through a program called State Coverage Insurance. And the letter from Sebelius clarifies that states like New Mexico fit the description of expansion states under Section 1905Z3 of the Social Security Act. And Sebelius' letter states that this population will indeed be considered newly eligible and that states like New Mexico will receive the enhanced 100% match for covering this population in 2014 if we expand Medicaid. Okay, next I'll introduce our speakers. Our first speaker is Elizabeth Luukkonen, a senior research fellow at the State Health Access Data Assistance Center located at the University of New Mexico. She manages SHADAC's technical assistance to states in the areas of data use, analysis, and evaluation, which is targeted at helping states plan for and implement health reform. She has over 10 years of experience in the health policy arena, where she has analyzed issues related to cost, access, and quality with a focus on using sound data to make informed policy decisions. Prior to joining SHADAC, Ms. Luukkonen served as senior research economist at the Minnesota Department of Health. Ms. Luukkonen holds a master's degree in public health from Columbia University and a bachelor's degree in economics from McGill University. Our second speaker is Carolyn Ingram, Senior Vice President at the Center for Healthcare Strategies, where her work focuses on assisting states in meeting the needs of the expansion population and developing the interface between Medicaid and the health insurance exchanges. She also oversees the Center for Healthcare Strategies' efforts to enhance the leadership capacity of Medicaid directors and integrate care for those on Medicare and Medicaid. Prior to joining CHCS, Ms. Ingram served as the director of New Mexico's Medicaid program from 2003 through 2010. Prior to her appointment to head New Mexico Medicaid, Ms. Ingram served as senior manager with the Lewin Group. From 1993 to 2001, she held several management positions within the New Mexico Human Service Department's Medicaid program. Ms. Ingram has a bachelor's degree from the University of Puget Sound and a master's degree in business from New Mexico State University. As a reminder, our webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button at the bottom right corner of your screen and typing your question. We will also post the PowerPoint presentation on the NCSL website with an audio archive of the webinar. I'd like to thank our excellent speakers. Now we'd like to open the floor for participant questions and answers. I think I'm going on here. We're going to move ahead on the presentation, and please make sure you ask your question to all panelists, and remember that the questions will remain anonymous.
Thanks, Michael. This is Elizabeth Luukkonen, again at SHADAC at the University of Minnesota, and I want to thank NCSL for hosting this webinar. It's a really important topic, and I think that Michael laid out the really important reasons that the Medicaid expansion decision is on the mind of probably all states. And as he said, we're going to discuss a tool that was developed by the State Health Reform Assistance Network to help states think about the Medicaid expansion decision from a financial perspective. Just to give you a little bit of context, the state network is a Robert Wood Johnson Foundation program that provides technical assistance to states to maximize coverage expansions under the ACA. And the focus of the program is to provide intensive TA to a diverse group of 10 states to help them develop successful implementation models. And then ultimately the program hopes to share those models and share the lessons from those models with all states. The focus of the program, as I said, is to provide technical assistance, and this is done in a variety of ways. It's provided through multidisciplinary teams. Much of the technical assistance is operational level and designed to meet states where they are, so really targeting and tailoring the TA to their needs. It's provided through teams of experts that can be utilized outside of the procurement processes, which I think everyone on the phone can agree can be both onerous and time-consuming. And the program really is designed to facilitate peer-to-peer learning and to inform federal policymaking as well. So again, for some context, and I think Michael highlighted most of this, as you know, the ACA expands Medicaid up to adults 19 to 64 with incomes at or below 138. States will receive 100% FMAP rates for the newly eligible through 2016, and those rates will decline gradually, reaching 90% in 2020. The Supreme Court ruling earlier this year didn't change the underlying Medicaid expansion provisions, but it did remove the ACA's enforcement authority for states choosing not to expand. So effectively, it allows states to opt out of this expansion or to make a decision on whether to expand. And once the state network, once we analyzed the Supreme Court's ruling, we realized it was going to be really important for states to have a tool to make that decision. And so thus we created a tool designed to guide states through a financial impact analysis of the Medicaid expansion. This tool was produced in collaboration by SHADAC, CHCS, and MNAT. And as you'll see as Carolyn goes through her slides, it really is a table shell outlining the key elements of a financial analysis, costs versus savings. Our goal really was to present the costs and savings equally and really to distill them down to the facts, taking the politics out of this analysis. In addition to outlining the key elements of this analysis, we have provided some text on considerations, guidance, and potential data sources for each of these elements. I think one important note is that the tool that we developed and much of the content that we're going to cover today is really limited to the financial considerations of a state's decision to expand Medicaid. So for instance, it excludes many important financial aspects of the ACA as a whole, so all non-optional provisions, such as developing a streamlined application process or changes to dish payments. That's not to say that these are not important, but the scope of what we're going to talk about today and the tool that we developed was really focused on the Medicaid expansion specifically. Within the tool, we cover, as I said, costs and savings, and I'm going to run through those quickly, but the bulk of what Carolyn's going to talk about is going to be the real detail on how to think about these. So for the cost, we highlight the cost of the newly eligible, the cost of the currently eligible but not enrolled, and this is sometimes termed the woodwork effect, though I must say that I think a nicer term is the welcome mat effect, and the administrative cost expansion. On the savings side, we highlight potential savings from transitioning current Medicaid populations to the newly eligible group, potential savings from reducing the spending on state programs for the uninsured, and other revenue gains and savings, as Carolyn will outline. And the reason that we sort of characterize these at a high level is we recognize that all of these will differ by state. But we do think that the general categories and key considerations and some of the data sources will be quite similar. So before we get into the details for the costs and the savings, I'm going to provide just a little bit of context that you might want to think about as you consider the analysis overall. And this is based on some work that we've done with our state network states. I think probably the most important framing comment is that this data relies, or this analysis rather, relies on three things: data, research-based estimates, and assumptions. So, if you think about the data that will go into this analysis, you can think about the PMPM rates that you have for your state, or even the FMAP rates that we know are set in stone. And these are things where there's probably not going to be a lot of debate or concern about their reliability. We also, this analysis relies on research-based assumptions. And here I'm thinking about something like the number of newly eligible. I think most states can use survey data to estimate the number of people below 138 who maybe are uninsured and might be newly eligible. And that's a number that, there might be a little bit of discussion, but it's a number that we can use research-based assumptions to get at. And then finally, there are assumptions that really have no empirical basis. And I think the perfect example in this case is take-up of the newly eligible. This is an area where we simply do not have an empirical basis to generate this assumption. And so it's going to be an educated guess. And what we recommend is, one of the best sources for some of these values are, previously published estimates, such as those by the Urban Institute or the CBO or other recognized and trusted sources. So I consider that as a framework as you're going through and pulling the different pieces of this analysis together. And because some of the key pieces of this analysis are based on assumptions, we really recommend that you do some sensitivity analysis to help identify driving assumptions. And an example that I would use is in one of the states we worked with, we had a lot of discussion about what employment growth factor to use. And when we did some sensitivity around that, we found that it really just did not drive major differences in the outcomes. So we decided to sort of make a decision, not belabor that point. On the other hand, the take-up of the newly eligible is an assumption that's going to drive this analysis quite a bit. So that is an area where you're going to want to spend some more time thinking about what you choose as your take-up assumption, and to get some buy-in from your leadership on that point, because it really will drive the analysis. Another way that you can deal with that issue is, given the uncertainty, consider developing an estimate range. So if you know that the take-up of the newly eligible is going to drive cost in one direction or the other, depending on what take-up you use, you might want to consider a range of take-up, and then ultimately have a range in your financial impact estimates. Related to that, I think one of the lessons that we have learned is that often within a state, several departments or programs might be working on similar issues. So your governor's office might be developing a budget, while your Medicaid office is looking at similar projections and estimates for their own internal work. Now, in an ideal world, everyone would use the same assumptions. We know that that's not always possible. But you might be able to get agreement on the small stuff. So for instance, the PMPM growth factor, or the phase-in effect of the expansion. These are fairly non-controversial, and at least you'll be on the same page on these smaller assumptions. And if you maintain a dialogue, you might at least be able to know what these other projections and estimates are using. A couple more considerations for the analysis that relate to data. In most cases, state data are best. We recognize that it's not always easy to get the data that's needed for this analysis, but I think that it's worth a try. And in the places where you simply don't have access to the data or the capacity to generate it, in many cases national data are available, but sometimes it's old or lacks state specificity. So in some cases, this can be modified to better fit your circumstances. For instance, you can trend it forward if it's old. Related to that, a lesson that we've learned from working with states is that it's extremely important to pay attention to your baseline. So if you, for instance, are using survey data as a baseline, a starting point for your analysis, we know that survey data, for instance, often undercount the number of Medicaid in a state. And if the number that you're using as a starting point doesn't resonate with policymakers, leadership, or your Medicaid department, you're going to run into huge problems, and the analysis is really going to lack credibility. So I think getting some buy-in and some sort of doing a smell test for your starting point data with a variety of people is a really useful exercise before you go down the road of the entire analysis with a baseline that doesn't resonate with people. The two last points that I would highlight are that transparency and documentation are extremely important. Given the uncertainty in a lot of these assumptions, you want to make sure that you are clearly citing data sources, assumptions, and research backing up those assumptions. We recognize that this level of detail is not always particularly palatable to policymakers, so you don't need to have it on all of the documentation that you produce. But I would definitely make sure that, somewhere hidden in your office, you have very clearly documented the steps that you went through to produce this analysis so that, A, you can reproduce it if asked, and you can answer any detailed questions if they come up. And then finally, I just wanted to mention one thing about scope. This tool, as I said, is really focused on a state's decision to expand Medicaid, but we recognize that many states are producing analyses that are broader than that. I think the important thing is to think about scope at the beginning so that you have some consistency and some logical framework to make unbiased choices for what costs and savings you include and what you don't as you go through the analysis. So with that sort of framing on how to think broadly about the analysis, I'm going to turn it over to Carolyn to really get into the details related to the costs and savings.
All right, thank you, Elizabeth. So again, my name is Carolyn Ingram, and I work at the Center for Healthcare Strategies. And one of the things that we do is work with states as they're going through these processes and trying to look at what type of analysis is needed. So what I'm going to do is walk you through a series of tables. And my goal, because I know a lot of states have already worked with different entities to come up with a lot of this analysis, is to try to make sure that we pull out here for you the details so that you can understand what is going into some of that analysis, and also so that you know what to ask for if you are looking at something and you don't see the pieces that you might want. I think one of the hardest things, of course, when I was Medicaid director is trying to put together something that is crisp and clean and that you could present to a legislative group in a short period of time and have them understand it. So often as these analyses are being put together, a lot of work has gone behind them, and sometimes that's not always brought forward. So hopefully when, in order to make it a clean, crisp presentation for your legislators. So hopefully when we're done with this session, you'll be able to see what goes into some of these buildups, and you'll know a little bit more detail behind it and be able to ask for that in your state if the work has already been done, if you're curious about what went behind the buildup. So the first chart is really just looking at the cost of the newly eligibles. This group is, of course, those new folks that are going to be coming into the program. And as Elizabeth stated, one of the factors, if you go down the left-hand side of the slide, that's going to be very maybe controversial or have a large effect is the take-up rate, or the number of people that are going to enroll in the program. So what, as a state, you need to do is, of course, look at the number of newly eligibles and do an estimate of how many people are going to be coming in over time from 2014 to 2020, but then also looking at these take-up rates and percentages. And there's quite a bit of literature out there with aggressive take-up rates, saying a lot of people are going to enroll. There's other experience out there that shows a less aggressive experience. And having come from a state, as Michael mentioned, where we did a Medicaid expansion already up to 200% of poverty, to be honest, in the beginning, there wasn't a very good take-up rate in that program. But it also didn't have the national attention behind it that you're going to have with health reform. And so as we get going to these slides, I'll talk a little bit more about that, because that national attention around the changes for health reform and around the changes for Medicaid expansion probably are really going to play into that take-up rate and push it a little bit higher than you would normally see when you're enrolling people into programs. So after you get that amount, you then come out of the table with a number on newly eligibles who you think are going to enroll. You can then add in there your per member per month cost or your per member per year cost to get what the total cost is going to be. And then you would apply your matching rate, and that FMAP there is for the federal Medicaid allotment that's going to be given to the states for the expansion. And as you can see, it's 100% in the beginning, and then in 2017 it starts to step down to 95%, then 94, and then 93, and so on, until the amount is set at 90% in 2020 and going forward. So this is really a way just to start to think about what your potential costs are going to be for the expansion. We'll talk in a little bit about some of the savings. So the next piece that you want to look at is the cost of those that are currently eligible but not enrolled. And this is where Elizabeth was talking about what you've heard, I'm sure, in meetings and things, is the woodwork effect, or I think she called it the welcome mat, which is nice. I've never heard the welcome mat, so I guess we could use both terms. But most people call this the woodwork effect. But this is looking at people who are eligible for your current Medicaid program, but they're not taking it up right now. And that's true in a lot of states. Most states have kid populations that are eligible for their program, but they're not enrolled. They have smaller adult populations often that are eligible, but they don't come in and get on the Medicaid program. And there's a lot of research behind why that occurs. But what is known right now, or what is expected, is that once the rules start to change and there's publications about outreach that's happening in these types of programs to be able to start the Medicaid expansion, or the exchange might come up in your state, or maybe it's not coming up in your state and it comes up in a neighboring state, there's going to be some attention to what's out there and available in terms of health insurance. And so people are going to come to try to get into the program whether your state does a Medicaid expansion or not. And so there's a need by states to go ahead and look at what this increased possible state Medicaid enrollment might be, and look at the matching rates that might correspond to that. So again, you would take the number of people you think are currently eligible for your Medicaid program, but they haven't signed up, and that would be at your current eligibility rate. You would then go back and apply a take-up percentage, and this is one area where it would be helpful to get agreement, of course, among people, because the take-up rate and how many people are going to sign up is going to vary by state. It's going to vary by what happens in your state. If you're a state that's pushing forward with outreach efforts and really going to go aggressive, that might be a higher take-up rate there. If it's a state where they're not going to participate in the Medicaid expansion and maybe they're not going to participate in the exchange, I would say the take-up rate would be much less in those states. So it's trying to get agreement on that amount. And then, of course, you can apply your per member per year cost again, come up with your total cost. And then you would have a matching rate there that's going to be the Medicaid matching funds that you get from the federal government. But in this case, because it's people that are currently eligible for your current program, it's going to be the regular Medicaid matching rate in your state. So whether that's 50-50 or closer to 75-25, that's the percentage rate that would go into that field. And I think the key takeaway from this slide is whether a state decides to expand or not, the literature right now is saying that pretty much every state, when the changes start to roll out and exchanges start to come up and other states look toward expansion, that there's going to be a bump in enrollment in this area because people are going to hear about it at a national level, whether your state decides to expand the Medicaid program or not. The next thing to start to consider are some of the administrative costs. And when I say administrative costs, I'm talking about things really to administer and run your Medicaid program. And I think a lot of states have started to look at this as they're starting to put together their budgets, of course, for the next legislative session, and trying to figure out, well, what does this really mean? What's going to be the impact on our Medicaid system? What's going to be the impact on the rest of our entitlement programs as this information starts to get out there? And so there's a couple of things here to consider. First of all, there are increased matching rates for a lot of the administrative functions that states do in order, or whether they're going to bring up the Medicaid expansion or not, states have the ability to get a higher matching rate for a lot of services. So the first consideration there is to know that there's a 90% matching for any type of build or operation to automate your eligibility and enrollment system for Medicaid. So even if you're a state that's not doing the Medicaid expansion, the letter that came out from Secretary Sebelius this week clarified you can still get that 90% match rate. And that's going to do a couple of things to your system. if you build a more streamlined eligibility system that's maybe automating certain functions, it's going to help save some of your administrative costs, because in the long run, you're going to have a simpler process. You're probably not going to need as many enrollment or eligibility workers. It's going to help reduce your costs. On the other hand, you're going to have more people starting to come to the program and applying for the program. Probably more people calling in on phone lines or asking questions of the program. And so there's going to have to be some assumption there of what kind of costs need to increase for that higher demand and that higher enrollment amount. So keep in mind that first, any state that's bringing up an exchange or moving to modernizing their Medicaid program in terms of their eligibility system, it's going to automate the approach, and maybe there'll be less caseworker time. But on the other hand, you're also going to have an influx of new applications. The next thing to keep in mind, of course, again, is that you'll get that 90% federal funding, and that you'll also be able to work with some of the health insurance exchange functions that are going to come up, if they're coming up in your state, around sharing some of the cost allocation around those administrative costs. The next thing that you want to look at as a state are some of the savings transitions that you're going to get. And right now, there are many states that currently cover people in the Medicaid program who will be transitioning to this newly eligible group if the state decides to expand the Medicaid program. So a state needs to look at what kind of savings that might represent in relation to what they're currently spending on these populations, using, of course, your regular Medicaid matching rate for these groups. So, for example, if you were a state that expanded eligibility for family planning services above 300% of poverty, a lot of those individuals will now, if a state decides to expand Medicaid, be eligible for the rest of those services. And so you're going to, as a state, look at possibly moving those people into the Medicaid expansion group to get their family planning services. So you would need to go through and look at what kind of money you're spending currently on those programs, and then look at the matching rate that you're going to be getting as you transition them into the expanded population. The next area to look at in terms of savings is really a reduction from state programs for the uninsured. A lot of states right now either partially fund or they fully fund programs for the uninsured. And this can be things like state-only funded programs in some places, uncompensated care funds, sometimes in the area of high-risk pools, states fund money there, obviously for public health services, and sometimes on hospital inpatient, and of course the cost for prisoners as they start to come out of care or people inside jails. And under the expanded Medicaid program, some portion of these individuals who have been receiving care and funded through other state mechanisms are going to be able to get services if a state expands under the Medicaid program. And so therefore it reduces some of the cost or frees up some of that spending potentially to be redirected in different areas. And so this is something I think that legislators are going to want to pay attention to in a lot of areas, because there may be an area where there's been severe underfunding in the state. Some people argue that, for example, mental health spending has been underfunded in a state. And so once the money is freed up, because people that are getting those services may be covered under Medicaid, it then enables the legislature to look at, do they want to reinvest that funding back into other mental health services in the state, or do they want to take that as a savings credit if they're going to expand the program and put that money back into a budget or fund it and use it to fund something else or as a savings to the state. The other area to look at are areas where there's revenue gains and savings. Again, many states collect revenue related to provisions of healthcare services, and that can be in the form of provider taxes, it can be in insurance taxes or other business taxes. And so the state's going to want to consider, of course, what the offsets are for those taxes and look at those types of cost savings. Of course, by expanding Medicaid, if the state chooses to do that, the number of healthcare services are going to increase that are rendered to people, because people are going to go out and access care. They're going to get prescriptions covered, and they're going to go to the doctor. They're going to go to the hospital. They're going to go to specialists. So those people, as they get paid for those services, where in the past maybe those people weren't accessing care, they weren't getting the prescriptions that they need, there's going to be increased revenue streams coming into the state. So the state will need to consider some of those revenue streams and those other costs as that starts to happen. There are a couple of other financial impacts that are important to take into consideration. And the first one is one that Michael mentioned earlier, but it's really the impact on disproportionate share hospital payments. You're going to want to, I think, look at what your DSH payments are in your state and know that under the law, those DSH payments are supposed to be reduced, because the understanding is, of course, those disproportionate share hospital payments were going to hospitals to help take care of the uninsured population. And the theory is that once the expansion comes up and once the exchange comes up, those uninsured people are going to start to decrease. Their numbers are going to decrease. So the payments that were in Medicaid budgets for these hospitals will also start to decrease. And it's very clear that that piece is in the law. The guidance hasn't come out yet about what the decrease is going to be or what effect it will have on each different state. There's a formula discussed in the law, and we know from the letter that came out from Secretary Sebelius this week that they're open to comments and working with states on what that will look like, the formula to reduce the disproportionate share hospital payments. But that's something that is going to be a large financial impact on the state, no matter if they decide to expand to the Medicaid population or not. So it's definitely something to be considering and putting into your budget discussion. The other area is the economic effect on the increase of health spending on the newly insured. A lot of states, and I'm not sure how many, but I have started to look into this, use different companies to help build their revenue forecasts for their economy in their state. And a lot of those different companies have started to build in, without much reflection, I think, the Medicaid expansion into those tax revenues. And so you're going to want to, as a state, consider, was that built into our revenue estimates, the estimate for these tax increases, as we're looking at what kind of revenue we're getting as the state and we're expecting to have come into our state? Because if it was built in and then there's a decision not to do the expansion, those impacts need to be adjusted back down, and an estimate of tax base needs to be decreased if a state's not going to do the expansion. Another area of financial impacts that needs to be considered is that on small employer groups. If a state decides not to do the Medicaid expansion, small employer groups are going to have to, under the law, go ahead and absorb some of the costs from the higher premiums, or make sure that if they have more than 50 employees, that they meet the employer requirement for coverage or pay the penalty back to the IRS. And so that's another consideration there for states in terms of looking at whether or not to do the expansion, or if you make the decision not to, is to consider what the effect is on those small employer groups in terms of their premium tax credits and things that are going to affect them. The other area, of course, for consideration is what does it look like in terms of crowd out of the existing private insurance sector if the Medicaid expansion does occur in your state. So just one other area to consider. Finally, in this presentation, we've given you quite a few resources that you can look at to gather further information. There's state analyses on a lot of this type of work that's already been done. So, for example, Arkansas has done some, Idaho, Indiana, Maryland, New Mexico, as Michael was mentioning, has already gotten their analysis done. Nebraska, Ohio, South Carolina. So they're all out there for you to get and look at in terms of the financial impact that might be occurring. These analyses are linked up in this presentation, and I'll work with NCSL to make sure that we get you these links, because obviously you have to click on them in the presentation to be able to go to each of those places. So we'll work with them to make sure they get out to you. And then another couple of different areas of resources that you can look at. Of course, the Kaiser Family Foundation always has great stuff on their site. Urban Institute's put out quite a few things. And then you can get copies of all of these letters, some health affair blogs, and postings by different bloggers by clicking on these additional resources. So we'll work with NCSL to make sure that you get those. So Michael, with that, I'm going to go ahead and turn it back over to you and see if folks have any additional questions that we can help answer, I think.
All right. Thank you very much, Carolyn and Elizabeth, for excellent presentations. We'll open up the floor for participant questions and answers. Again, to ask a question, please click on the question and answer button and type in your question. And make sure you ask your question to all panelists in that drop-down menu at the bottom. And remember that the questions will remain anonymous. Okay, we have one question for Elizabeth. The United States Health and Human Services Department has not yet released guidance on the basic health program. Now that there are states waiting for this guidance on the Medicaid expansion, is that something they're waiting for?
You know, I think there are a lot of reasons that states are waiting to make a decision on the Medicaid expansion. That said, I don't think that should stop states from developing financial analyses. So I think the key is just to make assumptions based on any guidance or, draft guidance that's out there and move forward. And I think, the politics of why states are waiting and the policy reasons quite varied, but Carolyn might have something to add on that.
No, I don't think I have more to add right now at this time. I mean, I think it'll be interesting to see now that the guidance has come out from the Secretary Sebelius what different states do, and then I think from there we'll know a little bit more information.
Right. Second question for Carolyn. What impact do you think the HHS decision not to allow states to partially expand Medicaid will have?
That's a good question. So we're waiting, I think, to hear what most of the states are going to do. I think there's some guessing by people out there on the blogs that more conservative states may not expand right away because they're going to wait to see what happens. On the other hand, what I'm hearing from Medicaid directors in a lot of those states is that if it looks like they need to go forward with the expansion because they wanted to cover the populations, they're also looking at what they can do to redesign their Medicaid programs and make them not what I'll say the good old days of the Medicaid program where the benefit packages were richer and the cost sharing was less or the personal responsibility was less. They're looking for new innovative things to do. And I think you'll start to see some of those states start to bring forward some of those innovations if they're going to expand to these newer populations.
Great. The next question is for Elizabeth. Currently, the Federal Center for Medicare and Medicaid Services has not released detailed guidance on the new MAGI eligibility determination or the new income guidelines. Do you think that states need this information to make an accurate fiscal assessment?
Well, in a perfect world, we would have that information. But I do think, this mainly impacts the populations that are currently enrolled that might be able to transfer to the newly eligible group. And in the states that we've worked with, this has not been huge numbers of people. It's mainly related to people who are currently on Medicaid due to a disability status. And, there's a question about whether there's going to be a disability proxy. We're not sure about that. I think the bottom line is they have given some information. For instance, if your currently eligible group has a limited benefit or there's a waiting list of some sort, we know with some certainty that those can be considered newly eligible. So, no, I think for the largest groups of people, I think we have fairly good guidance on whether we can consider them newly eligible. There are definitely some groups where there is uncertainty, but again, I think those groups are smaller, and the importance is just to take an educated guess and document it, and if it's a large group and you're really concerned, then maybe consider a range around that particular assumption.
The next question is for Carolyn, and I know this question was raised in New Mexico as well with differing estimates. Since the welcome mat or woodwork effect will take place regardless of whether a state expands Medicaid, do you think it should be included in the cost of expanding?
I do think it should be included, and I think states need to carefully consider, of course, then the factors around that, whether it's you know, an aggressive take-up rate or a less aggressive take-up rate. I think that no matter what happens in a state, if you decide to do the expansion or not, people are going to hear about exchanges coming up in other states. People are going to hear about Medicaid expansion coming up in other states, and they're going to wonder, am I eligible for these programs, or are my kids eligible for some of these programs? So they're going to come into those Medicaid offices. They're going to submit their applications online, whatever the practice is in your state, and they're going to check to see if they're eligible for some of it. Because what we're seeing when we test around outreach and information is we don't see the same stigma around the Medicaid program anymore when you do focus groups around why people enroll. And so I do think you'll start to see an increase in that utilization, increase in enrollment, and the question is how much will it be? And so what estimate goes into that budget number will be something you'll want to work on, if possible, and get agreement on with your Medicaid agency, and if not, at least with your budget analysts inside your budget shops around what the take-up amount will be for that population.
Michael, can I weigh in on that as well?
Please.
So from an analytics standpoint, one of the things that we've recommended is obviously to project the full amount of the welcome mat effect and then have the discussion about how much you attribute to the expansion specifically. And, you know, one of the things that you can do is do some sensitivity around this. So, you know, you can attribute 25% to Medicaid, you know, 50% and then 75%, and see how much of a difference it actually makes in your final financial projection. Because if you're a state that already has really high participation rates, the actual percentage is not going to make that much of a difference. And so this is an area where you can spend a lot of time spinning your wheels, but if you already have high participation rates to begin with, at the end of the day, the number that the percent of the welcome mat that you attribute to the Medicaid expansion directly and specifically is not going to make a huge difference. So again, the approach I would take is to estimate the total amount and then run some sensitivity analysis around the percentage of that effect that you attribute to Medicaid specifically.
That's a great add-on, Michael, that Elizabeth said. And the other thing to take into consideration is a lot of Medicaid agencies in their budget already project an enrollment growth. So you're going to want to check with them to see if they already built that effect in there, because a lot of agencies do that.
And I know in New Mexico there's been some discussion of the effect of changes in status. A great number of people may have children or become disabled after qualifying as newly eligible, and our Human Services Department has included has very much included those numbers in their estimates.
Yeah.
Okay, the next question is for Elizabeth. What is the research saying about an increase in the Children's Health Insurance Program, or CHIP? Will states see an increase in their current eligibility, their current population of eligible but not enrolled in CHIP?
Absolutely. I mean, I think when we develop the tool and we talk about previously eligible, we are both talking about kids and adults. And I think historically what we've seen is that for kids, the take-up rate is typically higher. It's not always the case, but it's typical that kids, if there's a big push around outreach or a big expansion, that the take-up rate among currently or previously eligible kids is higher than adults. So I would definitely include that in your analysis.
The next question is for Carolyn. Have you thought about modeling the cost of a state not expanding Medicaid, such as the cost of the uninsured, et cetera?
We haven't done work on that recently around what the cost is of the uninsured, but there is a lot of research done in that area. And Urban Institute has done some work in there. Kaiser has done some work about what it ends up costing a state in terms of uncompensated care funds and in terms of inappropriate emergency room use for things that could have been prevented and taken care of if they had been caught earlier. And so I do know there's a lot out there. I'm not sure, Elizabeth, if you have anything at the top of your head that you could supply. But
I think there is an Urban Institute brief that looked specifically about states opting out and the effects on the uninsured, at least on uninsured adults. And I believe that that is part of our resources, but I can double check, and if it's not on the resource list, maybe we can work with NCSL to send that out separately.
Okay.
All right, the next question is for Elizabeth. What estimates of workforce expansion or shortages are available? And are there any models of expanded ED utilization? And I assume they mean emergency department utilization.
Wow, so workforce is a tough one, you know, for many, many reasons. And I'm going to have to take a look at, we definitely don't have any resources in this, you know, in our resources section about that. So that's something I'm going to have to get back to NCSL about. In terms of ED use, I'm assuming that the questioner is talking about as people gain coverage, there might be increases in ED use. I mean, there's certainly empirical evidence to support, you know, the concept that as people gain insurance, there are increases in ED use. I would be a little hesitant to apply that directly to the newly eligible population because, you know, for many reasons, these people are different. But again, the Urban Institute did a really nice paper about the characteristics of new Medicaid enrollees under health reform, and that is definitely something that's in our resource list. So I would point you to that as a good resource for that.
Thank you. For Carolyn, can you talk about the estimated costs related to the cost to Medicaid for maintaining interoperability with the exchange?
Yeah, this is a big area that states are really starting to dive deep into right now, and we didn't actually get into the coverage too much in this in the presentation. But there's a requirement that the Medicaid agency is going to have to link with the exchange, because if a person comes to the exchange is going to have to determine if they're eligible for Medicaid. There has to be a eligibility determination made there. And how it gets done in the state, whether it is an electronic link back to the Medicaid agency and they make that decision, whether it's people at the exchange and the decisions made inside that IT function when people are making application, is going to differ in every state. But there is going to have to be a link back and forth between Medicaid and the exchange in order to get that eligibility information and put it into the Medicaid system. And so one of the great things about this is, as I was mentioning before, there are 90-10 matching rates that are available for those populations and that type of match. As you're building the interoperability and you're building the system, a lot of states have also received grants to be able to build their exchange pieces and the link that it's going to have back to the Medicaid system. So there is quite a bit of funding available on the federal side to make that work for states, but something that is going to be challenging for states as they really dive into it as we get down here to the actual implementation phases.
Great, thank you. For Elizabeth, is there any information available on the federal match for newly eligible non-citizens under the emergency Medicaid?
I don't think that I know of any, but this isn't an area that I track specifically. Carolyn,
so, yeah, I can jump in a little bit. So there, under the bill, as far as I know, there's no reimbursement for non-citizens for those types of services. However, under Medicaid, regular matching Medicaid funds, you can get emergency services reimbursed at your regular match level for cases of usually it's delivery of a pregnancy or a life or death situation where you're about to lose a limb or have other type of situation occur that's an emergency in terms of somebody's life. So that funding continues, but I don't believe there's any other funding for other services. So we can look a little bit more into that, I guess, and get with NCSL if we're wrong on that piece.
Next question is for Carolyn. Seems like there are two pieces here. Number one, whether or not to expand if a state hasn't. And number two, whether or not to reduce the expansion for expansion states, given that many will get coverage under the exchanges from 100% of the poverty level and up. Is it possible that there are really two questions here, given that there seems a plausible scenario under which expansion states may choose to actually move in the opposite direction, given such fiscal implications?
Yeah, I know. I see where you're coming from. So the first question, of course, is the base question, whether or not you're going to expand up to 138% of poverty and accept that matching rate for those services. But if you're a state that already expanded eligibility, like New Mexico, say, where you're at 200% of poverty, or a lot of other states have as well, D.C., Massachusetts, other states, I guess the question for them is, then do you go ahead and move some of those people that you expanded to at a greater rate off into the exchange? And then if you decide not to expand, what do you do with your current program now with those people? You will have to make that decision now that we have the letter from Secretary Sebelius. So the first question is that you decide if you're going to expand or not. And if your answer is no, we're not going to expand, then you need to look at how to transition those populations that you've got currently in your program. So one thing would be to move the people at higher levels of poverty onto the exchange where they can get tax credits. They can get some type of subsidy help there. But then you would have to look at what you're going to do with the lower income populations. They're eligible for tax credits and subsidies, but a lot of them are not going to be able to afford the coverage that's going to be available. So you'd have to look at what to transition those people to if you decide not to expand in some way. I think if you're a state that does decide to expand, then you're going to want to look at what you do with the coverage of people from 138 to 200% of poverty. If they go onto the exchange, are you a state that has a culture of coverage and you want to wrap some benefits around them? I know there's some states looking at that. Or do you want to just say, go ahead and enroll in an exchange product and off you go, getting your coverage if you're above 138% of poverty. Medicaid's really only going to cover people up to 138 in our state. So there's quite a few decisions and discussions that would come into play after that happens.
Right. And the next question is for Elizabeth. Do you believe some states will use the Enhanced Children's Health Insurance Program, or CHIP match, to underwrite the cost of Medicaid expansion?
Michael, I don't know if we lost Elizabeth there, so I can try and jump in on this one. I don't see how a state would exactly do that. Under the law right now, you're not allowed to use your CHIP funding to cover adults. There was a reauthorization of the CHIP funding that was passed in Congress, and they've gotten rid of that option. There were a couple states, of course, New Mexico and Michigan, who used to do that, but that option's not there anymore. There are quite a few cost allocation things that go on when you're looking at administering a Medicaid program about what costs get allocated to each program. And so each Medicaid agency will have to look at how much of time do their workers spend working on CHIP cases versus the new expansion cases versus their other entitlement programs. And they're able to cost allocate all the administration of that to different programs. So some of that will occur, but they couldn't really use their enhanced CHIP match to underwrite the cost of Medicaid, well, in a legal fashion.
Thanks. We'll direct the last question to Elizabeth then. Is a medical inflation rate factor included in the model? And is it as high as 6 to 7%?
Yeah, we recommend that you, at the very least, apply an inflation factor to the per member per year, per member per month cost that you're using. And, you know, some of this is state specific. I think the states that we have been working with, it's closer to 2 to 5%. But, you know, your state circumstances might be different, and you can definitely contact us and we can talk through those issues.
Great. Thank you very much. It looks like it's time to wrap up. I'd like to again thank today's speakers, Carolyn and Elizabeth, for your fantastic knowledge and sharing your insights with us, and all the attendees for your time and participation in today's conference. Thank you, and have a great day.